Hello, good evening, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David Regan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. Dr. Apajita, who normally does production, is unavailable this evening, but I'm joined by my two fellow senseis, Prof. Sile and Chris Caddy. Prof. Sile is in the Kingdom of Brunei, and Chris Caddy is in Sheffield, in the United Kingdom, and we're coming to you live from Kuala Lumpur. Welcome, and thank you for joining us. This is our 44th session with the Black Belt, 46th session with the Black Belt Academy of Surgical Skills with IECHO, and we are reaching 24 countries and expanding. I'm delighted that not only our online delivery, this is accredited by the Royal College of Surgeons of Edinburgh, but we have now got accreditation for our face-to-face program, which we have started in the Faculty of Medicine at the University of Malaya, and we've got 7 yellow belts and 4 red belts already. They're practicing hard for their orange belt graduation on the 11th of April. The paper that was looking at OSATs and the description of technical skills for basic surgery, we submitted to the Journal of Surgical Education and delighted to hear on Monday that it was accepted. The banana scoring model that we use for the black belt suturing skill is being accepted for an oral presentation at the International Surgical Week in Mexico City in April, and I'll be going there to present that work. As Chris Caddy and I often discuss, with basic surgical skills, you cannot see what you cannot see. And what we have tried to do at the Black Belt Academy is deconstruct what we regard are basic things and highlight the various issues and technical problems with that in practice. And this evening is about gloving and gowning. Now, I was going to do it at the sink, but because Dr. Apajita is not available, I need to be near the computer, and I want you to follow me, and we're going to mimic each other. But before we start, we need to think of where this all started. So Florence Nightingale transformed hospital care during the Crimean War by dramatically reducing deaths with rigorous cleaning, sanitation, ventilation, and hand hygiene, rather than the use of chemical disinfectants. Her reforms were based on environmental control of the disease, and we'll talk about the theatre environment at the end of this presentation. But it's basically down to careful nursing practice, and this was all implemented before we knew anything about germ theory. A decade later, Joseph Lister introduced carbolic acid, a phenol, into surgical practice to sterilize instruments, clean wounds, and reduce postoperative infections, inaugurating the era of antiseptic surgery. Florence Nightingale later acknowledged the value of antiseptics, but cautioned they should complement, not replace, fundamental hygiene measures. And together, her emphasis on sanitation and Lister's chemical antisepsis laid the foundations of modern infection prevention in healthcare. But I personally believe that infection in healthcare is still a human problem, and hand washing is the key. So the year is 1846, and our would-be hero is a Hungarian doctor named Ignaz Semmelweis. He was born in Hungary in 1818, and he graduated from the Vienna Medical School, where he specialized in obstetrics and worked at the Vienna General Hospital. Now, in the 19th century in Europe, childbed fever, or puerperal fever, was an important clinical public health problem with very high maternal mortality, and was thought to be caused by a miasma, evil vapors, epidemicity, or by the will of providence. And apart from bloodletting, there was no cure for this. So Semmelweis cared for these women during their illness. And when they died, he did autopsies on them. And he tried to correlate the autopsy findings to clinical symptomatology through secondary data analysis of maternal deaths. Now, this is what I like about Semmelweis. The first point was his powers of observation and reasoning. So the hospital had two maternity clinics. In the first clinic, all deliveries were made by physicians and medical students. In the second clinic, all were made by midwives. The maternal mortality in the first clinic was unexpectedly higher at 16% compared to 7% in the second clinic. And Semmelweis went through the differences between the two wards and started ruling out ideas. Right away, he discovered a big difference between the two clinics. In the midwife clinic, women gave birth on their sides. In the doctor's clinic, women gave birth on their backs. So he had women in the doctor's clinic give birth on their sides. The result? No effect. Then Semmelweis noticed that whenever someone on the ward died of childbed fever, a priest would walk slowly through the women's beds with an attendant ringing a bell. This time, Semmelweis theorized that the priest and the ringing bell terrified the women after birth, and they developed a fever, got sick, and died. So he made the priest change the route and ditch the bell. This had no effect. By now, Semmelweis was frustrated, and he took leave from his hospital duties and traveled to Venice. He hoped to break a good dose of art, and the sea would clear his head. When Semmelweis got back to the hospital, there was some sad news awaiting for him. One of his colleagues, a pathologist, had fallen ill and died. Semmelweis studied the pathologist's symptoms and realized the pathologist died from the same thing as the woman he had autopsied. Now, this was a clinical revelation. He immediately deduced that childbed fever wasn't something only women in childbirth got sick from. It was something other people in the hospital could get sick from as well. But it still didn't answer the question, why were more women dying in the doctor's clinic than midwife's clinic? And indeed, the ladies of the night knew this, the patients knew the difference. And when they went into labor, they asked to go to the midwife's clinic and not the doctor's. That's the difference that was perceived and known amongst the ladies of the night. The big difference, he noticed, on the doctor's ward and the maternal wards is that the doctors weren't doing autopsies. They're doing autopsies and the midwives weren't. So the physicians and medical students started their day doing autopsies on women who had died the previous night, and from the autopsy room proceeded directly to the labor room with no cleaning of hands, and delivered babies for the rest of the day. Surgical gloves weren't invented yet, and did so with bare hands. The midwives in the second clinic never conducted autopsies, and at the women were more likely to die after childbirth if they were attended by a male doctor compared with a midwife. So Semmelweis hypothesized that they were cadaverous particles, little pieces of corpse that the students and the doctors were getting on their hands from the cadavers they dissected. And when they delivered the babies, he postulated that these particles would get inside the woman and they'd develop the disease and die. So he then thought, well, adequate hand washing by the physicians and the medical students might reduce the transmission of these death particles. And he designed and implemented a hand washing policy for physicians and medical students. Before they entered the labor room, they were forced to brush under their fingernails and wash their hands in chlorine water until the skin became dry, and the chlorine was used because it removed the cadaveric smell. So he ordered his medical staff to start cleaning their hands and instruments, not just with soap, but with chlorine. He didn't know anything about germs at all as he did this. And at the end of the first year, the mortality rate in the first hospital dropped to 2.4%, a significant drop. So he established a causality by demonstrating a strong and specific temporal association with unclean hands, not knowing the etiological agent. So this association seemed implausible and incoherent to Semmelweis's seniors. They doubted the existence of death particles and rejected the idea of the transmission of disease through unholy hands, because they regarded their hands as physicians as holy and godlike. And there's an interesting article in LinkedIn about godlike behavior of surgeons. Semmelweis, however, was undiplomatic in his behavior, and he made more professional enemies than friends, and had to leave for Budapest to work in the city hospital for the rest of his life. He published a book called The Etiology, the Concept and Prevention of Puerperal Fever in 1860. And after 13 years of his study, the book had a very unwelcome response. He was criticized for poor language and unprofessional writing style. Semmelweis could not tolerate the criticism and suffered bouts of depression and rage, paranoia and forgetfulness. You'd think people would be thrilled that he had solved the problem, but they weren't at all. They took it as an affront to their professionalism, because he made out it was they who were giving the women childbed fever. Semmelweis was not very tactful and publicly berated people who disagreed with him, and he made some very influential enemies. Eventually, the doctors gave up and chlorine hand washing, and Semmelweis lost his job. But he kept on trying to convince doctors in other parts of Europe to wash with chlorine, but nobody would listen to him. He got angrier and angrier, and eventually strange. And there's been some speculation that he had a mental condition brought on maybe by syphilis or Alzheimer's. It's even suggested that some of his colleagues enticed him to a sanitarium. Thinking that he has been taken out, he went along voluntarily, but they left him there at the sanitarium. And he was committed, apparently not of his own accord, to a mental asylum. The sad ending to the story is that he was either beaten up or he physically beat the bars on his jail or room, and he ended up with an infection in his hand and died of the same sepsis that he had recorded with childbed fever. His contribution to medicine was recognized 20 years after his death, as the medical world became more receptive and wiser after Louis Pasteur's germ theory and the concept of antisepsis by Joseph Lister. And he is regarded as the father of hand hygiene and the father of infection control and the savior of mothers. And the story of this man, whose ideas could have saved a lot of lives and spared countless numbers of women of newborns, feverish and agonizing deaths. But this marked the beginning of the golden age, where physicians were expected to have scientific training. So doctors like Semmelweis were no longer thinking of illness as an imbalance caused by bad air or miasma or evil spirits. They looked instead into anatomy, and autopsies became common, and doctors got interested in numbers, audit, and collecting data. And what Semmelweis has discovered still holds true today. Hand washing is the most important tool in public health. It can help kids from getting flu, prevent the spread of diseases, and keep infections at bay. I love the advert that appears when you're standing on a metro and holding the bar. It says, whose hand are you holding today? And do you wash your hands after being out on public transport, handling money or smartphones, which are very dirty indeed? Even today, convincing healthcare providers to take hand washing seriously is a challenge. And one of the funniest studies, funny and peculiar studies, at a major medical conference, the hosts covered their hands in glitter and shook hands of everybody at the conference. And at the end of the day, they turned off the lights and had UV and asked people to look at their ties and clothes for glitter. The room was full of glitter. And I've noticed at conferences as well that people are not very fastidious by washing hands. And it's the most important way to prevent infections. I've been teaching 3.1 surgery, gowning and gloving over the past week or past 2 years as part of our surgical procedure instructions, and worked out with the students that I probably gowned and gloved around 15,000 times. That's 9 years of general surgery and 22 plus 97, 29 years of cardiac surgery. That's a lot of gowning and gloving. But I still, once a year, would ask the sister to watch me gown and glove and sign me off. Because I sat behind the perfusion machine and I could look down at the washing station, washcloth, and observe junior staff scrub. I've even observed senior staff scrub, and I'm afraid there's a degree of complacency and laziness in that. When we go into theatre, we should be wearing clean apparel and scrubs. These scrubs should not go outside the hospital and certainly should not go in public areas. They are for theatre. We often always asked to wear a cap. Now, I do like the concept of a cloth cap, particularly with your name and role displayed in the front. And this has been fantastic in the introduction of non-operative technical skills and awareness of people in theatre. I look at putting on the hat is a bit like putting on your hat going into a swimming pool, prevents the hair falling out. By way of observation, note some surgeons put it over the ears or under the ears, and some tie it at the back, some tie it at the front. And if you have a beard, the hoods should come down and cover the beard. So properly attired, we enter theatre and we go to the washcloth. Now, I want you to follow me, because the getting ready for surgery and the scrubbing for surgery is almost like a ritual. I know a colleague who preferred one tap, and he would scrub up when everybody else had scrubbed up, because that was a moment of reflection and mental preparation for an operation. He also said he had a lucky tap. But the washcloth is at counter height, and the taps, as you know, have got paddles, and there are two soaps. There is a pink soap, a chlorhexidine soap, and a brown povidone iodine soap. I'm not sure what's in your hospital, but I prefer the povidone iodine because the chlorhexidine pink soap for me felt like fingernails on a blackboard. As I hold my hand up, I'm looking at a ring on my finger. And indeed, all jewelry should be removed. But if you have to keep it on, the jewelry should not have any crevices or patterns in it and should be plain. But particular attention should be given to cleaning under the ring and the ring itself. Best take it off. It's interesting, in my practice in Iaido, in the Japan Club on Sundays, we asked to take the ring off because it mentally separates you from the outside so you can focus on what you're doing on the inside. As I'm looking at my hands as well and looking at the nails, and I want you just to adjust the table. And if you hear it clicking, your fingernails are too long. And I would inspect the fingernails of the junior staff. If you've got a hobby involving cooking or gardening or motoring, that where your hands get grimy, this is the time now in your training to wear gloves for your hobby. And therefore, your hands are clean and your nails are clean for theatre. Let's scrub up. So with me, we're going to turn on the taps. Now, the taps, hot water in hospitals is extremely hot because that prevents Legionnaire's disease. But we don't want it too hot. The other thing is, if you have the flow too fast and you put your hand underneath, you're going to get splashed with water. Not only is that uncomfortable, but you're breaking down the barrier of clean cotton between you and the environment. This is a physical barrier for both you and the patient. So you don't want it wet. So as we turn the tap on, I want you to feel go not too hot, not too cold, just right. Now to the side, we will have brushes, and the brushes come packed. There might be disposable brushes, this, or there might be actual brushes, but we're going to take the brush, and the brush is to clean the nails. But usually in the disposable pack, there's a little plastic scraper, and I love the German word, it's called Nagelringer. And the ch, I'm told in Arabic, is exactly that. Ch, beneath the nails, dirt. Ch in Arabic is dirt. So with a Nagelringer, with a ch, under the running water, we are now going to spend time deliberately cleaning our fingernails. And you have to be meticulous about this. And you clean it until you get no more ch from underneath the fingernails. And you do it on both hands. And that will probably take you a minute. Now, I'm going to put some soap on the brush. Lots of soap, using the pump. And note that I've got my elbows up and away from the body. So I'm not dripping down my front, and the water's running from my hands off my elbow into the sink. So keep your elbows up. Lots of soap on the brush, and now I'm going to gently brush the nails. Put your fingers together like that and rock your nails. Hand gently over the brush to make sure that you cover the curve of the nail. Don't do it too hard because you'll rip your nail beds, and we're going to give that 30 seconds for this hand. If necessary, look at the clock, but there's no shortcut. And this is where your mental preparation for an operation and rehearsal can happen as well. That's 30 seconds, rinse off, more soap on the other side, and we do that again. Another 30 seconds. Now, if you're allergic to any soaps or got skin condition, there are other soaps available, but you need to ask theatre staff or even a consultant dermatologist. That's 30 seconds. Rinse off. This side is the sponge. And a bit like the brush, you don't use the brush on the skin and you don't brush or sponge your hands vigorously because it excoriates and increases the bacterial count. But I use the sponge if it's there, lots of soap on the sponge, and I'll sponge my hands thoroughly. To take off gross dirt. And once I've done the hands thoroughly, then I'd come down one arm, one direction, all the way around, not too vigorously, but sponging to the elbow. Rinse off, not all soap, and I'll do that again. So this is another minute. And then I come down the arm to the elbow, and I've done my general wash. Can throw that away. Now I'm going to do the same again with my hands. Another forearm and hand wash. A lot of soap, good lather around the hands, and I'm going to particularly come round my arm to the elbow and rinse off. That's 30 seconds that side. Soap, good lather again around the hands, and then come down the forearm and rinse off. So we've done a general hand and forearm wash. That's 4 minutes. Now we're going to focus on the hands themselves. And you will see the diagrams in theatres and on the wards, and it's the same. Areas of the hand that are not cleaned, the side, the interdigital spaces, the side of the hand, the back and the front interdigital spaces, the palm of the hand, the base of the hand, the wrist, and the back of the fingers. So the way you scrub and the order you do it in, I don't mind, but you have to attend to all those areas. So again, lots of soap, please, on your hands, elbows up, away from my side, and I'm going side to side, palm to palm, into digital spaces, side there, okay, back of the hand again, side again, base, back of the hand there, side again, base of the thumb, back of the fingers in the palm, back of the fingers in the palm, around the wrists, rinse off. That's another minute. Now, if at any stage you had an itch, I would be wearing a mask anyway, but if you had an itch, that's another wash. And it's interesting, itching and a tickle, the involuntary movement and tendency to do that, that's another wash. So lots of soap on hands. This is penultimate. Again, good soap, side, palm to palm, side, palm to back, side, and then the other side as well, back, palms, base of the thumb, base of the thumb, back of the finger, the palms, back of the finger with the palms, and around the wrists. Rinse off. Coming up for the last wash, this is now 7 minutes, lots of soap on the hands, good lather, and we do that thoroughly again. It was interesting to watch an OSCE station, and somebody had to demonstrate good hand hygiene at a sink, and they tried to get soap out of this empty soap dispenser, and I felt sorry for them because there was and there's not much soap in the hand. But when they came to doing this, they go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, you get the drift. They did that for the whole time of scrubbing. 10 out of 10 for 10 rubs in each area. But called it out and counted it in military style. It did bring a smile to my face as I looked at it. So there you go, and round the wrist and off. Okay, and I'm going to now turn off the taps. Okay, and let the water drip off my elbows. And now I'm ready to go to pick up my gown. My gown would have been placed on a stainless steel trolley that's been rubbed down with alcohol with a sterile drape put across it. I'm going to pause there in our process to open up a gown to show you some principles how to open up practices. Now, some places got disposable gowns, other places have got material gowns made of cotton, again sterilized, but wrapped up in the same way. Like many surgical instruments, dressing packs, they're packed with paper on one side, plastic on the outside. And this on the inside is sterile. If you see any condensation inside that, it means it's not sterile. To open up these gowns, there's a technique, and the technique applies to opening up all sterilized surgical packets. So if you look at this, there's a short seam at that side, and there is a seam at the top where it separates but sealed. So we're going to break the seal. And remember, although my hands on the inside of this is clean, so this would have been laid out before I instruct. So I'm going to break the seal all the way along, careful not to touch the inside. So once I've opened it up, I'm going to continue to open it up. And as I open it up, I'm going to turn my hands this way. And turning this way, I'm opening the gown up from height of maybe 10 centimeters above the table and let the gown fall out. So see that action? Separate it up, turned over, and opened it up. It's the same with gloves. There's a clear plastic side, another side, sealed at that end, an opportunity to open the sealed stem. And note that I've got my thumbs down both sides, fingers underneath, and I'm separating the seal and then turning it upside down and laying it on my sterile tray. You don't touch anything on that inside until your hands are scrubbed. So we'll go back, and now our hands are scrubbed, and I'll just take you over to the top. So on the inside of this gown, the further we go inside, the more sterile it gets. When you open up any sterile pack, it's folded. You can pick up one fold and hold it out. And as you hold it out, you'll see that the other side comes up as well. And there's a memory in this, a bit like the proline that we use. Because there's a memory in it, a little trick is to just hold the sides out so it doesn't fall back in. And then lift the other side up. There you go. I'm not touching the inside. And I'm just holding and stretching it so it doesn't fall back in. It's folded, so I'm going to open that up. And again, I have now opened up the inside. I don't touch the inside. You have two towels on the top. And I'll come over just to show you drying of the hands. So I take a towel, it's folded in half, and I use the two halves. The top half, you've got two, one from each hand. The top half, I dab around my fingers. Okay, around my fingers and hand, and around the wrist. I drop that half, pick up the bottom half, and I put it on my forearm, making sure that skin does not touch the skin. And now, with pronation and supination on my forearm, I dab. I don't rub, I dab. One direction from the wrist to the elbow. thoroughly drying all the way to the bottom. I come round the elbow and I discard. A common problem now is that many people then scrunch this up. And in scrunching it up, because this touched the elbow, I've now desterilized my left hand. Do not scrunch up. Repeat the process with the other side. Pick the gown up, top half, bottom half, hand, forearm. Again, making sure that you thoroughly dry around your fingers. Once that's dry, I take that side. And again, skin does not touch skin. Dab, 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 all the way around forearm. Off the elbow, don't scrunch it up, and I discard. So, going to bring you over to the top again. What I'm looking at there is effectively the inside of the gown. The outside of the gown is on the inside, and the outside of the gown is the most sterile, and we don't touch the outside of the gown, and that's why we look at the inside. Our outside is going to go into the inside of the gown, so our outside never touches the outside. All sounds confusing, but it will become obvious as we go through. The gown is folded such I'm looking at it, the inside. I'll bring it up again. You have the collar of the gown, the spine, it sort of opens up like a book. But I need to put the collar smiling down towards me. And as I do that, you'll see there a pocket and there a pocket. Okay? These pockets represent the beginning of the arms. So I can put my hands into those arms. Now, the important thing to remember is, in opening this up, I got to let the gown fall. I don't shake it vigorously because I'm shaking a lot of air around, particles. And I will not have the gown falling with the ties on the outside. So I create space. I must not let the gown, that's the outside, touch anything. That is the most sterile bit. You're looking at it, and I'm stepping into the gown. My outside's going into the inside and never touching the outside, which you can see from your side. You with me? Will become clear. So I hold the gown open and I gently let it fall. I don't shake it vigorously, and all being well, you'll see that the drape ties are on the outside. I shrug the gown onto my shoulders, and my hands never leave the end of the gown. And this is what closed gown and gloving is all about, is you do not touch the outside. I should never see the pinkies, all right? In this position, you stand there, somebody will come along to tie you up. Be patient as a student, because at this part of theatre practice, you will see that the patient's going on the table, being positioned by the ODPs, the diathermy is being put on, the nurses are bringing in the trolleys, they're doing the counts. There's a lot of activity. I'm afraid as a student and as a beginner in surgery, you are the last consideration for gowning and glove. Please be patient, somebody would tie you up. I do not want to see your fingers. Now, I'm going to just pull this off because there's an important part of this process that I want you to appreciate. I'm going to fold my fingers out of the way like that and pinch. And this pinch is important because this pinch is going to hold the glove in place as I pull the glove over my hand and then open my hand into the glove. So keep your fingers out the way, pinch. When I pull it over my hand, I'm going to let go of the pinch and I'm going to expand my fingers. And if I've aligned my glove properly, and we'll come to that now, my fingers will be in the right position for each finger. It's a bit like putting your trousers on and you find both legs going down the trouser. If we don't do this properly, that's what will happen. The pinch, therefore, is a pinch of the seam between the white of the gown and the blue. Pinch that seam and a good pinch pressure. like that, because that's what we're going to need. So come back, you haven't seen my hand, and this is the most difficult part of gowning and gloving, because you've got a baggy gown on, and in my case, it hasn't been done up at the back, and I'm doing a pinch. And now I have to gently open up my gloves. Okay, I gently open up my gloves, and I open them up like a book, bring you over so you can see. There they are. So left is on the left, right is on the right. Okay. Now the gloves are folded, and at no stage do we touch the glove itself, even with the outside of the gown. So we're going to pick the glove up, and as I pick it up, it's dangling down like that. And you see this thumb is towards you, and it's usually given away because you can see the size of the glove. I'm putting that on my forearm, having picked it up, and putting it on my forearm, thumb to thumb, fingers down my forearm. Thumb to thumb, fingers down my forearm. This is critical, because if you don't get this orientation right, you're not going to be able to pull your glove over your hand as if you're putting on a sweatshirt. And that's what effectively you're doing. I am now going to take the front cuff of this. I'm going to pull it over my hand, cognizant of my hands have not been sweaty. And there you go. And as I've done that, I've let go and opened my hands up. I can now hold the glove and the gown, and I'm going to wriggle it onto my hand. My hands are sweaty. So there you go. This is a common thing that happens. And I'm glad I've done it online. But I'm going to come back to that in a moment, because I'm not going to touch the outside. But at least my fingers are in the right trouser leg, so to speak. But I never use this hand to start playing around with that, because that's desterilizing the glove. But at least now I've got more use of my hand, and I'm not operating like a pterodactyl. So I can pick up the other glove, pick it up. There you go. Thumbs towards you. I'm putting it on my forearm, thumb to thumb, fingers down, forearm, and I can do the same again. Pull it over my hand and pull the glove. And this is what happens when you haven't dried your hands, sweaty hands. This is exactly what happens. And this is the part that students find difficult. But at least you can see there, my fingers are aligned. I can now touch glove to glove, because I'm on the inside and I'm not touching the outside. And as I pull my sleeve down, I want to make sure that the white of the sleeve stays underneath the glove. And I'm going to pull it down. There you go. And now touch the ends and align, and the other side. So because I haven't washed my hands, alcohol, a little bit sweaty, but there you go. I am now clean. Okay, I've put my gloves on first, and now I can adjust the tension in my fingers. What size gloves do you wear? There are different sizes. In effect, they need to sit comfortably on your fingers, not too tight. You should not have baggy bits at the end, and it should enable you to feel. There you go. Note the cuff is sitting there underneath the glove, and I like it at the base of my hand, because it is actually sits there and a sleeve does not leave. In this position, my hands should never go above my clavicles, should never go beyond the anterior pectoral line, should never go below the waist. You should never fold them underneath your arms, because they're sterile. So the best place to put your hands is to put them folded in front of you, Sifistona, or in martial arts, Surigetsu, because that's where most damage is done with a weapon or a punch. So there you go, folded in front of you. and wait to be invited to the table. You'll note that your gown is quite billowy, but we're going to tie it up. So to tie it up, there's usually a tag, a blue end, and you're going to take your tag in your right hand, okay? You're going to pass that to a person who's going to hold the tag, and then you're going to turn, and I'll cheat, putting it on, turn gently anti-clockwise on the table and pick it up. And I've just proven you can't do it yourself. And then you pick up the left side and tie. You're now tied up. Wait to be invited to the table. There's lots of equipment, tubing, electrical wires, etc. Remember that this is baggy. If you touch anything, you've desterilized. Not a problem. You have to go and put another gown on. There's no compromise. My outside is now sterile. My hands are there, but my back, because it's been tied up, is not sterile. So as you walk around theatre, your front, blue to blue, blue or green is normally sterile field, you keep your sterile front towards the sterile field. Your back, which is not sterile, you keep to anything that's not sterile. And you move carefully around theatre. You don't push things out of the way. And if you haven't got a clear path, please ask. So, you have stepped yourself onto the inside of the gown, and the outside of the gown is sterile, and your hands are sterile. And really, it's this window that is the most sterile. And as we were scrubbing up, our fingers got more and more sterile, a bit like concentration at the loop of Henry. It's cleaner, 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 elbows are dirty. Okay? We don't walk around theatre. You see films walking around like this, as if they're looking for divine inspiration. No, it doesn't come with that. It comes with practice. At the end of the operation, albeit you're a careful surgeon, you might have blood or other fluids on your outside. Hopefully not much, because we need to be tidy as surgeons. But now, the outside of your gown is dirty, and you're on the inside, and you're cleaner than the outside. Everything's relative, isn't it? But we don't tear our gown off the end of our operation, all right? We say, please, could you undo me at the back? And then you shrug your gown off, and then shrugging your gown off, you can pull it off, and as you pull it off, note that my gloves have rolled down my hands. My hands outside of that is dirty, so the hand I can take outside to outside, pick it up, take the glove off, all right, and then finger on the inside, and take my glove off and disperse. I don't shoot it across the room. Bad habit, not very good. So the scrubbing up process that I've just described must be done every day on every list. And the only exception would be the nails. However, if you leave theatre for a comfort break, or it's commonplace in this culture to use your hands to eat, you'll need the brush again to get the ha for underneath your fingernails. So it's a wash and a full soap and water wash again. If you're changing your gown, or you've got a short period of time between cases and you do not leave theatre, you may take your gown off, take your gloves off, inspect your hands, because there's a remarkable number of holes in gloves at the end of an operation. If you've got blood on it, soap and water wash again. Remember, with a dry, etc. If they look clean and there's no blood on it and there's no hole in your glove, you may use alcohol, again, elbow to pump it onto your hand, and go through that process of every side of your hand and your wrists, let dry with alcohol, and then you can put your gown and gloves on again. But at the beginning of every list, a proper full scrub will take you, not probably, will take you 7 minutes. And there is no compromise. So my colleagues will come in and make comment on this, and they're welcome to now, but we can then talk about the environment. We talked about moving around theatre, and for ladies, just briefly on the environment, no makeup, no mascara, no earrings. And if you wear a headdress, certainly in Malaysia, there are sterile headdresses and staff will help put them on. What is interesting when thinking about the environment and how we gown and glove, I recall that there was a surgical valve company in Leeds that were taking valves from pigs, putting them in pots, and we're taking the valve out of the pot and putting the aortic valve in a patient. And I'll ask you a question. Which do you think was cleaner? Taking the valve from the pig aorta, putting it in a pot and making it, or taking it out of the pot and putting it in the patient? Any thoughts from anybody? In the chat, I'll ask. Any thoughts in the chat from anybody? Which cleaner? Pig to pot or pot to patient? Well, industry have to work to 6 sigma, which is 6 decimal places. So the pig to pot, you're quite right. There is no compromise in sterility. And what they had in their workroom with a maximum of 20 people at any one time was double entry doors and a clean area into a cleaner area, and then put your shoes on in full mask, full drapes, full coverage of the face and nose, and full gowning. And they worked in there for 4 to 5 hour shifts before coming out. The traffic was kept to a minimum. In my cardiac theatre, one of the SHOs counted the door openings. And we usually in a cardiac theatre have 12 to 15 people in there. But the door openings each hour were up to 60 times an hour. That wasn't a door opening. That was a flutter of the door. And each time we do that, the positive ventilation that from the roof blowing air out gets disrupted. And then the circulation of the air is poor. Newspapers in theatre with the anaesthetists, as soon as we opened the newspapers, so the team who did the sterile monitoring of the valve factory came into my theatre to monitor. I had permission, but then they said, you can't do it while you're operating. I said, of course we can do it when we're operating, because that's the most pertinent time. And they said, well, we only check it when the theatre's empty. Kind of silly that, isn't it? Because the patient's on the table, the chest is open, the bone's exposed and the wound's exposed, so you want it the cleanest at that moment. But when you open a newspaper, 10,000 particles count in the air, it went up. A simple white swab on the floor, behind the equipment, and you don't want to know what was on the floor, on the mid-level or on the theatre light. You don't need something fancy to monitor it. Just take a clean white tissue over the surface. Is it clean? Is it not? And I was concerned one day with it, and I asked the team to come down, and a lot of people came down with clipboards and said, yeah. I said, I've got the privilege of operating on this person who's expecting a zero defect heart operation, but this is the swab on the floor. Yes, we'll get the cleaners in to monitor it. But I said to them, that's fine. And well, they said, we'll have a meeting. I said, well, MOPS came forth, not meetings. What was interesting in this study, we looked at the areas. None of the areas reached 6 sigma. 95% of the areas failed 2 sigma, and 5% of the areas were too dirty to count. That included the wash trough, the box from which we got our gloves, and the stainless steel trolley that was used to serve the instruments. And that was because that was the only vehicle to remove contaminated material from theatre, which is the other point in designing theatres. Your patient entry and patient exit is one. Your scrub up area is clean, enter to theatre. All dirty material, contaminated material, leaving theatre should go down a different corridor by a different route. not the same corridor. So the design of the theatre is important, and the flow of air through the theatre is important, and how people move and behave in theatre is important. In orthopedic surgery in particular, because of the risk of implants and infection is so profound, sterility is taken to another level with charming tents and full, almost hazmat-like gowning and gloving. I always thought I envied them because I was putting aortic valves in, cutting through the bone, and these people were putting hip implants in. But their traffic policies were absolutely rigid, and you weren't allowed in, woe betide you, but it didn't stop people walking in cardiac theatre. And it comes down to perceptions and the way people behave. If you set a speed limit, they say, we're on motorway, I'll drive at 90 because it's a motorway, but that's not the speed limit. So how do you actually change people's perceptions? And I think sterility and attention to detail like this is setting speed limits. How do you get people to change speed limits? And it's interesting to think that some theatres have red line policies that you're not allowed to enter the theatre because there's a red line. Whereas other cases, people walk to the door and open the door, hi, how are you, etc. And I worked in Oxford where one hospital had a red line policy, the other one, people walk to the door. There's no difference in wound infection rates between the two theatres. And then in another hospital, the old theatre upstairs had big bay windows that opened up onto the cricket ground. And they were open in the summer for fresh air. And again, wound infection was less there. So there's more to it than meets the eye, but it doesn't mean to say that we should compromise on our discipline and our rigor in attention to detail. And hand washing and scrubbing up is one thing that everybody can and should do all the time, no excuse. And when I look at trainees scrubbing up, I sat at a fusion machine, I could look down at the scrub up area, and if I saw hands drop or this, would they give, excuse me, would you like to do that again? And that is why I actually asked the theatre nurse to watch me scrub up every year and sign me off as doing it, because we all are liable for bad habits. We can always pick up bad habits. And it's worthwhile remembering and checking yourself on a regular basis. So with that, I'd ask my fellow sensei, Chris Kelly and Rosile, to join me to discuss their interpretations of scrubbing up and their insights. For me, the closed gown is the only way to put it on, and folding your fingers away and pinching and pulling it over your hand and doing that ensures that you get the right leg into the right leg and your thumb is aligned. And it's transitioning from that to that and getting the hands working is the most difficult part. And it's kind of fun watching the 3.1 students learning this. They get it. And the gloves going on, funning away, but it all comes down to orientating thumb to thumb, fingers down, forearm, and putting it over your hand like that. Thank you. And questions, observations, and comments from my fellow sensei. Mr. Kelly, Prof. Seeley, are you there? Prof. Seeley.
Hi, Prof. Yeah, I thought Prof. Chris want to comment first. Yeah.
He's not there.
He is there.
Hmm.
No, Sile, please proceed. Semmelweis led the way, and he was an obstetrician. So there was a lot of learning in that.
Very good indeed. Prof. Seeley, your observations and comments.
Okay. Thank you very much, Prof. David. And then Prof. Chris also giving me priority to give the comment. Yeah. I do respect to both of you. I think both of you are my senior and then more skills. Yeah. But I really thanks Prof. David that when you start the floor with the maternal mortality and morbidity, then so this is what really give me insight, to looking at it for the statistics. Yeah, 100% right, because we are aiming for the ultimate safety of the patients. Yeah, all right. There are a lot of the stories in government hospitals with the mother end up with the endometritis for multiple VEs, vaginal examinations, by started with the medical students and then house officers, then checked by the senior medical officers, and then counter checked by the lecturers, and then finally come in with the consultants. So it's like when someone who had it, they call it patients end up with the fever and sepsis, and so we heard about a lot of these kind of stories, especially in the teaching and training hospitals. So the first thing is, of course, we also want to learn, the juniors want to learn, and then also we also want to teach, but we should not compromise with the safety of the patient. Yeah, that's the first point. I got few points. Yeah. The first one is that, before we gown, I think we have to choose ourselves the appropriate the gloves and the appropriate size of glove and the gown, because when someone open up and then, oh, this is not my size, and then throw it into the dustbin and then get another one. So that is not not sustainability, especially in this era. We should have, is like save the consumables. So I think we ourselves to open up, or otherwise some theaters, they have a list of the surgeons, the name, and then the glove size, and then the gown size written on the wall. In some theaters, they make it, yeah, because they want us to help us, yeah. But in a place where there is no list, and then the first thing before we wash hand, we open our gown first, yeah. So this is the first practice, yeah. Because when we want to teach that for the gowning, and the first thing I think we should start mention about the choose of appropriate glove and the gown, and then open up, get ready for yourself before we start washing, because the student might think that we wash our hand first and then only we open up. So it's like they
I interrupted it I interrupted and pointed it out.
sure.
You choose your gown and glove, you make sure they're out properly on the table before you
Yes, Prof.
you don't
Thank
touch
you very much.
unless
Yes, yeah.
Absolutely.
I noticed that, Prof. Yeah, thank you very much. But the student might mistaken the
Of
steps.
course.
Yeah. All right. Thank you very much. I'm so sorry, Prof. Yeah.
Very good point. Very good point.
Yes. The second one is you mentioned about the mental preparation. Yeah, mental preparation. So it's like, in fact, before we scrub, on the mental preparation, I start one day before. Yeah. Because this is what my teacher, my mentors, I always respect him, Prof. Siva, and he always check our nails. Yeah. So it's like, we make our habits. Yeah. And then every Sunday, yes, every Sunday we must cut the nails, and our nails getting longer. Then twice a week we must cut the nails. Yeah. So why is that? Because when we scrub with him, when he see the nails long, and then he will say, never mind, you go back to the hostel and cut the nails and come back. So this is what he asks even houseman to do that, or medical officer, the ordered person. So it's like that's happened to me when it's like the husband want to scrub, and then, Prof, can I scrub with you? And okay, then at that point, I just check the nails, if the nails long.
A simple way of doing that is ask them to percuss the table. And if you hear the
Yes,
clicking of the nail on the table, the nail.
just true. So they should prepare mentally one day ahead
Yeah,
if they
well,
want to scrub.
you've got to have clean hands all the time.
Sure. Yeah. All right.
You
Yeah.
don't
So
want to be examined by anybody who's got car grease or cooking oils, etc., under the fingernails. So
definitely.
that's your hobby. Terrific. Now wear gloves for your hobby, so that your hands are clean for the patient.
Yeah. Those days we are really respect to the OT, operation theater sisters. In fact, operation theater OT sisters, they check our nails, and then we should not have even nail painting in the girls. Yeah.
Nail polish? No, definitely not. Mascara?
Yeah.
Makeup? Not. Earrings? No.
No dingling earrings.
And
No dingling
you may have a
earrings.
stud, but as long as
Yes, yeah, it's a button.
it's fine.
Button, not dingling,
No
not at all.
dingling, no necklaces either.
No necklaces, yeah.
Because
All right.
the amount of
Sure.
bacteria that's underneath there.
Definitely, Prof. Yeah.
That's huge.
Yeah. And during the hand washing, in fact, I mean, it's like we respect every religious. Then you might have your own way of praying, the spiritually. Your mind, your operation during the surgery, your mind should be very pure, mind, and that make you stronger, So it's like
I agree with you there, and that's the quiet time at the tap, scrubbing up and standing there, scrubbing up, you're emptying the mind, and you focus on
yes,
vibration.
cooling down.
It's
Yes, true.
part of that ritual. And if you think
Yeah.
of taking penalties in football, for example, they pause before they kick the ball, and you'll notice they've all got little ticks or movements, rituals to help them focus. And I think for surgery, and certainly for me, the scrubbing up process is part of that focus and zanshin that is required.
Exactly. Because what I noticed that the young generation, they will be talking about the footballs last night, and like, so it's like no side talk, it's like, to me, when I want to start, the scrub, and then this is my time to go down and cite. So it's like, rather than I count, I cite my prayer. So it's like after this kind of this, and then I remember that this will be 5 minutes for this time, it's like, rather than counting. So this is what I mean. This is my practice that I want to share for my mental preparation. Yeah. And I have a questions, Prof, because some centers, they say that it is whether the water is, whether it is, the pure or clean, but some centers, they don't like it to, I don't know how you practice in UK, in Malaysia. Malaysia, we still use the tap water. In Brunei also, we still use the tap water.
Tap water, the hospital water is fine with soap, with chlorhexidine soap or povidone iodine soap. I'm not sure. What soap do you have in your theatre, Prof?
Yes, Prof. Yeah, because
What
in
soap
some
do you have? Do you
area,
have brown soap or pink soap in your theatre?
sure, yeah, right. Because in some area, in a hot zone,
Yeah.
that they have a, very lack of water, and like in a places that, what would you like to, they don't even have a running tap waters. All right. So what you would like to suggest, whether this is like, the chlorhexidine itself.
Well, I think as long as your hands are wet and you've got a good soap, you can turn the taps off as you're doing it. So you're reducing the time.
Yes.
There's a lot of movement with the elbows, and you have
Yes.
to be cognizant that you're not touching anything, because your hands touching,
Definitely.
that's another wash. So
yeah,
I note on the wards and scrubbing, they do teach the surgeons, the students, to turn the taps off so it's not running all the time, because
yes.
water problem.
Yeah, because every minute there are the gallons of
Indeed.
the water
Indeed.
are wasting. So it is like sustainability, and then
Indeed.
This is another way of saving environment as well. And at the same time, like sometimes the students or the surgeons, they put on the glove, they've been talking and, it's like walking along and then wearing the glove. So
Yes.
it's like this, the glove must drop somewhere else. Yeah. Right. So this is what my teacher taught. You put your glove on the table and then you on your glove on the table itself. So if it is dropped, it will drop on the table rather than the floor.
Yeah.
Yeah. All right. Sometimes the people just walk around and then on the glove.
Yeah, but
which
if
is
you
not
put it
right.
on closed, if you're putting your hand
Yes.
closed,
Yes.
you
Yeah.
can't walk
Exactly.
around and do that.
Yes. Exactly.
I sometimes actually, to be honest, put it on closed, teachers put on closed. But in theatre, I'd ask the nurse to hold the glove and I put my hand in the glove.
Yes. Yeah.
And
Exactly.
I got the right inverted commas tension on my fingers that way.
Yes. Yeah.
That's, I suppose that's a consultant privilege and a privilege to have somebody hold the glove
Yes.
and put your hand
Hold
in.
the glove and put it on. Yeah.
And I just want to be gloved by you is the song, yeah.
Yes.
But no, you have to learn how to put it on closed. And it's quite remarkable how people get it quite.
Excellent. Yeah. The other point is that you mentioned about the close, the
Yeah.
close gown method,
Yes.
So it's like your hand should not come out,
No.
and then when we put on the glove, but sometimes, it's like I have seen some surgeons after they putting the gown, their hands out and they are adjusting the gown with their hand, with their hand, So I think this is which is not acceptable. I mean, anytime, any movement, whatever we do, our aim, is to save the patient's life,
Indeed.
rather than to protect yourself. So, which is not acceptable. So
But
that
as I
very
pointed out,
strict.
is that
Yeah.
some of the worst transgressors of sterility are the most senior doctors.
Yes.
They're bad habits, and they're a bit like the doctors that Semmelweis was trying to persuade. Oh, well, I know better. No, not at all. It's a fundamental skill, and it's a routine, and there's no compromise, and there's no shortcut.
Exactly.
But
Exactly.
you turn around to the consultant and say, no, that wasn't good.
Mm-mm.
That's an interesting one, isn't it? If I was in theatre with a consultant colleague doing that, coming to help me at the table, I'd say, I'm sorry, but I'm not happy with the scrub up. But I know that wouldn't go down very well at all. But I think if we are going to maintain discipline in theatre as the leads in theatre, we need to actually ensure that we ourselves are accountable. And that's why I asked Sister to check my scrubbing up and sign me off every year to ensure that I didn't pick up bad habits.
Exactly, Prof. So we learn those days also, even we should not lean our body on on the table,
No,
on the, yes, yeah. All right. Because what nowadays, the young nurses and all that, even they open the glove, when you ask the new glove, you want to change a glove, or the surgical sutures, for example, they open up on the table and then they open that and then dropping that.
wave it up and
Yeah.
down. No,
Yes.
open,
So
let
that
it
means
drop.
that you are dropping all the droplets to
Yes,
the sterile table.
indeed.
Should not. So
Indeed.
it should be outside the
Outside
table. Yes, open
drop.
up,
Yes.
and then let someone to grasp with the that the instrument nurse to get with the sponge forceps or something like that,
Indeed.
rather than someone is dropping on the
Indeed.
table.
And it's the same
Yeah.
with the
I think-
gowns, etc. All that fluttering is upsetting the sterile.
Yes.
Definitely not.
Yeah. So it's like the generation should improve, rather than
I
going.
wouldn't blame it on the generation. I think we need to
Yes.
teach it properly, but I'm also
Yes, yeah.
equally critical of our generation
Yeah,
You've become complacent. A bit like
definitely.
Semmelweis's colleagues. There's no room for complacency on this at all.
Yeah,
And that's why I
yeah.
say fundamental to infection problems in hospitals, etc., is a human problem.
Yes.
The human
Yeah.
problem is if
We should
everybody
not
was,
relax our
yeah, if
discipline.
everybody was fastidious and attended to sterility and proper
Yes.
washing and gowning, infection would fall. Definitely, infection would fall.
Yeah.
Very good points.
Yeah. I learned, the operation theater setting when I was in Myanmar, when
Mm.
I working on the OT operation theater setting and all that. It's like there is an airlock system. The door
Yes,
has to close all the time,
yes,
and then even the slippers, the changing the OT slippers, and we've been too restricted. Yeah.
yeah.
So that's a reason
But,
that, yeah.
but another simple thing
Then
is that,
regular changing of the HEPA filter,
yeah,
these are so critical.
it's like cleaning of your footwear. And
Yeah.
if you get blood on your shoes, you don't leave them in theatre changing room for somebody to clean them. You clean them yourself.
Yes. Yes. Yeah. I clean
And you
myself.
I clean myself.
Yes.
And you see people
That's
just putting
true.
their shoes off to the side and they're covered in blood. And you just think,
Yes.
and
And then even you should change the toilet slipper.
yes,
If you want to go to sleep, but yeah, then
it-
use, yeah. All
it's
right.
sloppy, isn't it? Well,
Yes, no
people
one
say
knows
about this.
that. No one knows that. But you know yourself. And then
Yeah,
God knows. Yeah.
yeah. And then you go down theatre corridors where they bring in theatre gowns and blues, and they're all put up on racks, and they get thrown on the floor, and they all end up on the floor, and you say, no, no,
The
no.
discipline.
Yeah,
Discipline. Yeah.
that's what it is. It's discipline. And it's speed limits. I mean, this is a speed limit, but you wouldn't drive 80 miles an hour through a 30-mile-an-hour speed limit area when you pass the school. That'd be folly. But people push it on a motorway. And this is the basic behavior of humans. They push it, push it, push it. And there's some things you can't and should not push. Mr. Caddy, your thoughts and observations.
Thank you very much.
Thank you.
Multiple. Yeah. So once again, you're highlighting NOTs, the non-technical skills.
Yeah.
So you're there talking about, so NOTs, we currently break into 4 different zones. And number 1 there is leadership. So you, as the senior surgeon there, set the tempo for the whole theatre.
Mm-hmm.
And everybody will be watching what you do. So it's important that you do things correctly.
Mm-hmm.
The next thing is decision making. So what you've done there is you've shown how to open one type of gown,
Yeah.
and that's the gown that you have chosen or been supplied with. But if I'm an orthopedic surgeon or a cardiac surgeon, I may use a different type of gown. So the different thicknesses, some are water resistant, some are heavier weight. And so you need to decide what sort of gown the team is going to use and which members of the team are going to use which gowns. So the surgeon and his assistant may require to use a particular type of gown, whereas the scrub nurse and runners do not require that.
And of course, any plastic waterproof aprons are underneath the gown, and any
Yep.
radiological protection and lead aprons are underneath the gown as well.
Um, so when you were demonstrating, you opened up the pack, but before you did that, you'd opened the gowns, and then you opened the pack over your over your gloves. So you then had to
Yeah,
find your gloves
indeed.
beneath it.
Yeah, the gloves should be opened up.
It's about timing and attention to detail.
Yeah, indeed. So that,
And
as Sile said, you'd have a sterile area, you would have chosen your gown, you would have opened it up, you'd open up your gloves as well. They might be on top, or you get the gloves opened up later once you've got the gown out, but you don't go fishing for it because you likely, once you've got the gown on, to desterilize, indeed.
So even with gloves, so there are lots of different types of gloves. So when I'm doing microsurgery, have very fine gloves, and others will use more robust gloves. Orthopedic surgeons may double glove, which once again is something that you need to move on to. When do you double glove? When don't you double glove? I know you have a particular thing about double gloving
Yes.
and your ability to
Fear.
manipulate instruments, hepatitis, etc. But but you need to get students to pause and think, what am I doing here and why am I doing it?
Well, if you
Um,
routinely double glove, terrific. But if you don't,
yeah.
and then try and double glove to do something fine, you lose your fidelity in the most difficult of situations.
Trainees also need to understand if they have a latex allergy
Good
as to
point.
the different
And
types of
patients.
gloves
And
and
patients
patients.
too
Yeah.
might have latex
So
allergies.
patients with latex allergy need to be done at the beginning of the list. So when you're planning your list, anybody that has a latex allergy, you put early on in the list so that they're less likely to be exposed to allergens during the running of the list. So one thing which you pointed out was to dry your hands well, because if you haven't dried your hands, you will struggle to put on latex gloves. Which is why you, as a senior surgeon, prefer to do your dunking rather than the closed. So you need to teach the trainees or the next generation to do closed gloving as you did. But if they're doing that, they need to ensure meticulous drying of the hands, and you can't rush that.
Indeed.
If you don't, your gloves don't fit properly, and the rest of the operation is difficult to proceed with. You talked about the preps. So you've got povidone iodine, chlorhexidine. I, like you, used povidone iodine for years and years and years, and then all of a sudden I started getting rashes.
Really?
So I then moved to chlorhexidine, used that for a long time, and again I started developing rashes. So that's where your occupational health medicine specialist or a dermatologist can prescribe a different type of preparation for your hands.
Did you swap back to povidone iodine?
I tried it, but it just flares
Same
up
thing
again.
again. Interesting.
Yeah.
And I think that's in an occupational hazard in some respect. And as you say, you've got to go to occupational health and a dermatologist. Suffice to say, if you've got any injuries on the hands, some of them might preclude you from operating altogether because you can't cover it. And if you've got an infection or cuts on the hands, likewise. But as you say,
So these are all
these are part
knots.
of the
Yeah.
thinking, aren't they?
But once again, the trainee at the beginning of their career is unaware. They don't know what they don't know.
Indeed.
And it's a question of, do they ask questions? What do I do here? So when you enter into a theatre environment, it's about being curious about what is standard practice in that theatre. Ask, because nobody's going to be offended if you ask. Listen, and then implement what they're saying.
And usually, as some advice noted, the nurses are better doing this than doctors.
Yeah. And the other thing to be aware of is systems in theatres. So you were talking about shoes being cleaned. Once again, that depends on where you are. Are they your shoes that have been issued to you and only you're going to wear them? So many surgeons will use clogs, shoes, Wellington boots, whatever. It depends, once again, the type of surgery that you're doing and what that system requires for you to use in that environment. And you only do that.
Yeah. And also
Ask.
in shoes, again, think about your arch support and your posture and your movement. I wear clogs. I like the wooden clogs because it gave me arch support. What did you wear?
Uh, when I started out, I was provided with clogs,
Yeah,
but not all hospitals have clogs.
yeah.
So as I move from one to another, the other thing is that they need to be grounded so that you don't build up electrostatic in it.
Hmm. Hmm.
And you need to once again be aware of that in the operating theatre. Theatre design is also important, and you need to be aware of where the scrub up area is. Many hospitals had a separate scrub up area which you had to go into.
Mm.
More modern hospitals have laminar flow within the whole theatre area, so you
Mm.
can scrub anywhere, and the mist is pushed down and out rather than around the rest of the theatre environment.
Mm.
But once again, these are all things which come with time, but you're only aware of if you ask the questions and see what's happening and find out why do they do it like that?
Indeed.
So Siri was talking about changing the HEPA filters. If you turn to your medical student and say, "What's a HEPA filter?" You'll be met with a blank look.
I looked at
Um,
HEPA filters in our theatres. Some of them had holes this big in them, and dung beetles could crawl through it.
yeah, yeah,
And then what's interesting as well is that the in pipes, the air takes, happen to come from the ambulance bay. So if the ambulance bay was busy, these diesel engines would be putting diesel fumes into theatre as well. Um, just fantastic. So design is also important. I know of a theatre, those new theatres that are put up in Bath, and they forgot to put stairs between theatre sterilization room and theatres. So when the carryman or lift broke, there was no means of getting sterile theatres up in no staircase. You know, there's lots of it. And another thing to contemplate, as I have noticed also, there you go, one person, okay, 12 people in theatre, as with 3.1 and our teaching group, all that is waste. And if you look at that, cellophane and plastic. And hospitals are huge producers of waste. Now, the clinical waste goes into yellow bins because it's dirty, but the cost of disposal is 100 times that of the black bins as well. And not only is this cost, but is it sustainable and environmentally friendly? And we talked about water and environment as well. So when you put all of these together, this simple subject has become quite complicated, hasn't it? And
yeah.
quite nuanced.
Similarly with water, you talked about using your elbows to turn them on. Many places now have automatic, so you've got a laser which you break, that then has the water running,
Mm.
stops when you move your hands away and put more soap
But
onto it.
have
Um,
you found the wash troughs and everything kind of low? So you end up doing this underneath the taps. And at the end of the day,
well, so
yeah,
I've been involved with theatre design,
yeah,
and that's one of the things that you have to take into account. Who is going to be working in that particular
yeah.
theatre? How much splash do you get? So it's about the not just the temperature of the water, but the pressure of the water. So you're talking about turning the taps on at the beginning of the case. But if you've got automatic taps, you need to have them at just the right pressure so you don't get spray that comes up out of the trough
And all down your
over
front.
you and
Yeah,
onto the floor.
yeah.
And then you're walking through water, spreading that around the theatre. So it has a knock-on effect to the whole theatre.
Wow.
So all of it comes down to systems thinking
Yeah,
and getting people to think about what they're doing, why they're doing it, and how can it be done better.
indeed. And that's true of everything we do everywhere. And we've
Yeah.
just taken one element of it. Any comments?
Thank you very much, Chris. Yeah, the wonderful contributions and
Very
yeah,
excellent contributions with Prof. Celia,
yeah.
Chris
Thank
Cuddy.
you very much.
Any comments from any of the participants? Any Observations or questions?
Well, John Rund has said perhaps that's why the BBAS is so important, as these basic skills are needed at the earliest point of training, not years after. And that's why we need to get the medical students and the young doctors so that they don't have to unlearn bad habits.
Indeed, because that becomes very difficult.
Yeah.
So with that, we'd like to say thank you very much, my fellow senseis. Thank you very much for joining us. Wish you well, and we'll see you next week. So thank you.
Thank you.